Sometimes we design interventions with great intention, but they do not work as designed. Especially after COVID, there has been increased and really unprecedented demand for mental health services. And we know we do not have enough psychiatrists to serve the population. This discovery was made decades ago, and a clinical model called the collaborative care model emerged. And the idea behind the model is that primary care practices get connected to a psychiatrist, and that the psychiatrist can support primary care physicians in reviewing all of the mental health cases in that practice and providing recommendations for the primary care physician and care team to execute. And the result of that is you're able to really increase the scale and the reach of the psychiatrist who has specialized knowledge in the management of mental health conditions. And so what health plans have done to advance this model is create a billing code, which allows the primary care practice to bill for these services and recover payment and be able to use those dollars to pay for this program. So we introduced those codes, and what we have observed is really slow adoption of the codes and slower than we'd like adoption of the collaborative care model. And some of the conclusions that the literature has shown about this is, number one, anytime there's a change in billing is a source of administrative burden and complexity for physician practices. So when we change the processes around that, we always see slow uptake. So requiring physicians to change the way they code and to know when to use a code is hard. Number two is when there's uncertainty about the money that will come in from the health plan for this service, it's hard for the practice to know how much money they have to invest up front in the program. And for this program, not only does the practice need to retain a psychiatrist, but there are other practice supports that need to be built in to really implement this program reliably at the practice level. So we've heard that as a complexity. And the other simple thing is awareness. There's so much change happening in these practices that it really takes a lot of education and support to get these implemented at scale. Another one that I'll say as a health plan chief medical officer is if not all health plans are offering the code, that is a source of stress and complexity for the primary care practices that need to implement it. Now, I'm hopeful there's quite a bit of attention on the concept of primary care mental health integration, and we are seeing an increase in the use of these codes, still not to the level that we'd like, and communities are starting to come together to understand what those drivers are that can be used to improve it.